Welcome, everyone. I see everyone's trickling in, and hopefully you can hear me well. My name is Juliana Cruza, and I'm the physical therapist at the Lewis Headache Center. And I want to welcome you to today's webinar for In the News. We have a fantastic topic of GLP-1s agonists in use in migraine. Dr. Knievel is a neurologist and professor of neurology, and she is our director at the Lewis Headache Center at the Barrow Neurological Institute. And she got her degree at Kirksville College of Osteopathic Medicine in Kirksville, Missouri. And then she did her residency in neurology at BNI, where she focused on neuromuscular fellowship. And she is also licensed by the Arizona Board for Headache Neurology. And we're so excited to have her here. For Allison Crane, she is our amazing PCP who we frequently use. She works here at Dignity Health at St. Joseph Hospital and Medical Center. She got her undergraduate in molecular and cellular biology, as well as her medical degree from the University of Arizona in Tucson. And then she did her residency here at St. Joe's, and she got trained by Dr. Knievel and has been an amazing person for us to use outside of our Lewis Headache Center for headache management. She is also board certified as a headache practitioner, I should say. So thank you, Dr. Knievel and Dr. Crane, for coming aboard, and I will yield the floor to you all.
Thank you, Juliana. Yeah, I'm really excited. I think Dr. Crane and I are kind of a good team to present this topic because Dr. Crane prescribes the GLP-1 agonist in her primary care practice, and she also has a headache practice. And as Juliana said, we're both board certified in headache medicine. So I asked her to help present from the GLP-1 agonist side because I don't know as much about these drugs, but we both know migraine. So there was a paper published in the Headache Journal, the Advance. This is the paper, effectiveness and tolerability of liraglutide. So this is one of the many, as a lot of people know, there's quite a lot of GLP-1 agonists out, and Dr. Crane's going to talk about that a little bit more. But this is a GLP-1 agonist as an add-on treatment for patients with obesity, but also high-frequency migraine. So high-frequency episodic or chronic migraine. So this was the study published in Journal Headache, and I'm going to go through this study later after Dr. Crane and I give a little bit of background. But then there's many news articles about this. This is just one that was talking about a diabetes drug and how it could cut migraine days in half. So this is how the news summarized this article, and they did a very good job of that. So this is the news article, one of the many, if anyone wants to specifically look that up, but we're going to go into it in a lot more detail. So just a little bit of background here. Migraine is a disorder of sensory processing within the peripheral and central nervous system. There's a change in the likelihood of activation of the sensory nervous system, a change in sensory processing that can be influenced by and activated by the environment or activate spontaneously. So essentially, people with migraine are wired differently a little bit. Their sensory nervous system activates differently and spontaneously to create pain, light sensitivity, cognitive slowing, nausea, and neck pain, and all of the other features that occur in migraine. And a part of this pathway involves a neuropeptide transmitter called CGRP, or calcitonin gene-related peptide. And this is medication this is a neuropeptide that is the target of a lot of the new headache treatments that we have. We also know that migraine and headache can be triggered or worsened by increases in intracranial pressure. So increase in the volume and pressure of the spinal fluid. And this could possibly, and it seems to increase the release of CGRP. So there's another diagnosis called idiopathic intracranial hypertension, which is another diagnosis that we treat at the Lewis Headache Center, and it has a lot of overlap with migraine. The headaches can look quite a lot like migraine. Someone who has a history of migraine, who has worsening of their headaches, it could be because they have elevated spinal fluid pressure or idiopathic intracranial hypertension. And I'll explain that a little bit more later. Risk factors for refractory migraine are quite similar to the risk factors for idiopathic intracranial hypertension, one of those being weight gain and obesity. Some patients with migraine could have slightly elevated intracranial pressures. If we do spinal tap on people with migraine, sometimes we find slightly elevated pressure. We also find that people with migraine have improvement in their migraine type headache after pulling off spinal fluid with a lumbar puncture, also known as a spinal tap. We also, some of the migraine preventive medications that we use actually have a slight intracranial pressure lowering effect. They actually reduce the intracranial pressure by reducing the production of spinal fluid in the brain. Topiramate or Topamax is one of the medications that can do that. So there is a relationship between obesity, migraine, and intracranial pressure. And all of these things become relevant when we talk about the GLP-1 agonist medications. This is just a diagram to kind of show a little bit more about where this is happening. So this blue thing here, this is the trigeminal nerve, and specifically this first branch here, this innervates the face, the forehead, the top of the head, but also the dura, which is the membrane that covers the brain and holds in the spinal fluid. So this trigeminal nerve and all these branches release CGRP, which is depicted here by these yellow dots. When CGRP is released, it activates other pathways that go centrally into the brain that create the migraine cascade, along with other peptides, but CGRP is the one that we understand the best and also the one that has treatments targeted towards it. So this is the dura, and this is happening in the dura. So one of the thoughts is that if there's increased spinal fluid pressure, it actually puts more it actually can put more pressure and tension on the dura and perhaps cause more release of CGRP in migraine. Reducing that pressure could perhaps lower that rate of CGRP release and actually help with headache. Some of that is kind of a theory as far as the pressure is related, but as we'll see, more study is needed in this area, but the paper that we're going to be presenting shows a little bit more about how this could potentially, in fact, be the case.
So what is the relationship between obesity and migraine? There's still a good amount we don't fully understand about the specific molecular mechanisms that connect obesity and migraine, and certainly more investigation is needed. But what we do know comes from all the information we have about how obesity impacts the body in general, and genetic and epidemiologic studies that show a strong link between obesity and migraine. Epidemiologically, migraine is overrepresented in the obese population. There's been shown to be a 21% increase in migraine diagnosis when compared to non-obese controls. Patients with migraine and obesity are more likely to have a chronic migraine diagnosis, which suggests that obesity is a risk factor for migraine chronification, which means having a very high frequency of attacks. This higher attack frequency is demonstrated in a dose-dependent relationship, meaning the higher the BMI, the more migraine days on average. Also, obesity is associated with a BMI-dependent increase in migraine disability, which suggests that the severity of the attacks is also increased. Pharmacotherapeutics or medications for obesity either directly modify the processing of macronutrients from food, or they aim at altering gut neuropeptides that in turn modulate metabolism and feeding behavior. Surgery can mechanically alter how food is processed, but the primary mode of weight loss with surgery is actually through rebalancing the gut neuropeptides, which ultimately facilitates weight loss. So intuitively, we would think that if obesity contributes to the severity and frequency of migraine, then weight loss should lead to an improvement of symptoms. And indeed, it has been shown that in a recent meta-analysis that compiles information from multiple studies, that weight loss, independent of the type of intervention, reduces headache frequency, duration, severity, and disability. And this outcome was demonstrated regardless of the starting BMI. This suggests that weight loss is a potential therapeutic strategy for migraine However, in the weight loss studies, there were pretty low numbers. So again, more research is needed to assess the efficacy of weight loss as a migraine treatment. Next slide, please. So obesity is a precipitating factor of many comorbidities: cancer, hypertension or high blood pressure, diabetes, and all-cause mortality, which is driven by the biochemical and hormonal dysfunction that affects every aspect of the body, including the nervous system. Obesity adversely affects the vasculature, and migraine pain may also be associated with changes in cerebral vasculature to some degree. There is an increased level of pro-inflammatory cytokines and a decreased level of anti-inflammatory cytokines. So we can define obesity as both a metabolic disease and a state of low-grade inflammation. This chronic state of inflammation could be linked to the proposed role of neuroinflammation in migraine pathways. The trigeminovascular system and the dura are areas where migraine pain is thought to originate and are outside of the blood-brain barrier and are exposed to these cytokines. So we don't know for sure the effects of obesity on inflammation and endocrinology of the trigeminovascular system, but this is one proposed mechanism. Next slide. There are biochemical and genetic changes in obesity that affect migraine as well. So cortical spreading depression is a temporary ionic imbalance in the brain tissue that impacts function. And one of the clinical features of this is migraine aura. Leptin is a chemical that is released from fat cells and tells our brain that we're not hungry. Infusion of leptin in rats leads to cortical spreading depression. It's also been found that higher levels of leptin are found in obese females, as we might expect, but also non-obese patients with migraine with aura were found to have higher leptin levels. And CGRP, as she described previously, is a neurotransmitter that is a key player in the development of migraine. Has been shown that women with obesity had elevated plasma levels of CGRP compared to controls. So obesity itself is a complex multifactorial disease. And it's clear that there are strong genetic components as well. So it's been shown that polymorphisms, or small little changes in the DNA sequence in multiple nervous system genes, are associated with elevated BMI, and there are also polymorphisms associated with lower BMIs. Therefore, this is a polygenic risk, making some individuals more likely to develop obesity. And same goes for migraine. Possibly up to 50% of the risk of developing migraine is due to genetics. It's thought that there are many migraine promoting polymorphisms, meaning that migraine susceptibility is also a consequence of polygenic risk, but that's still not necessarily definitive or determinative, just that it lowers an individual's threshold for migraine, making other factors more likely to provoke these attacks. Back to you.
All right, thank you. Thanks, Dr. Crane. So I just wanted to talk about this diagnosis of idiopathic intracranial hypertension, just kind of continuing on from what Dr. Crane talked about. So migraine is associated with obesity. We see obesity raising the risk of increased frequency of migraine attacks, and also, perhaps resistance to treatment and basically chronification of migraine. But when Dr. Crane and I and all of the providers at the Lewis Headache Center, when we see patients who are having increased frequency of their migraine headaches that are refractory to our treatments, or especially if they develop a persistent baseline headache, we start to worry about idiopathic intracranial hypertension, especially in our obese patients. Because this needs to be treated differently, and this needs to be monitored differently than we would treat someone with migraine. We certainly treat patients with idiopathic intracranial hypertension for migraine if they also have migraine headaches, and very often they do. But it's really important for us to make this diagnosis if it exists, because the treatment is different and the risks are higher. So idiopathic intracranial hypertension is a headache associated with increased spinal fluid pressure. The headache often looks like migraine, but it can actually be a baseline persistent pressure headache that's often worse at night. And but persists throughout the day, and it can feel like a whole head pressure. It can also have superimposed migraine attacks, which can often increase in frequency in the setting of idiopathic intracranial hypertension development. And the headache would increase often along with weight gain. There's a very strong association with obesity and weight gain, and in fact, weight loss can be it is the best treatment and can actually be curative. The problem is why the headaches occur in idiopathic intracranial hypertension is due to reduced spinal fluid reabsorption. So the brain is continuously making and reabsorbing spinal fluid. It actually turns over several times per day. And the brain production of spinal fluid remains the same, but the spinal fluid reabsorption seems to go down in the setting of obesity. And we have some ideas why that happens, but we're not completely sure why that happens. Some of the main concerns with this are refractory headaches and associated disability, but the main concern that we have is vision impairment. It can actually cause a constriction of the visual field, which can lead to blindness, which can be permanent. So we monitor very, very closely with our neuro-ophthalmology colleagues to ensure that we are doing everything that we can to preserve vision. We treat with weight loss. We utilize a dietitian. We utilize other medications for treatment of comorbidities and diabetes. But one of the medications that can be used and can be quite beneficial for this are the GLP-1 agonist class of medications, partially because they help with weight loss, but also because they have been shown to lower the spinal fluid pressure, even independent of weight loss. So that's what this slide talks about. So this is a study done in Dr. Sinclair's lab in Birmingham, England. She's really one of the world experts in intracranial hypertension. This study was done on rats, but they actually looked at patients with rats with a model. They make rats that actually develop intracranial hypertension, and they gave them GLP-1 receptor antagonists. And they actually had, get this to stop popping up, sorry. Okay, oop. So they gave them the GLP-1 agonists, and then they found that the intracranial pressure lowered more than it did with topiramate and also acetazolamide, which acetazolamide is the gold standard treatment that we use for treating idiopathic intracranial hypertension. And how those two medications, topiramate and acetazolamide, work is they reduce the production of spinal fluid in the brain. So even though the problem in intracranial hypertension is reabsorption, the treatment is actually to reduce the production of spinal fluid. But as I said, the ultimate treatment tends to be weight loss, and that can actually be curative. So we saw lowered intracranial pressure in the rats who had both normal intracranial pressure, but also the ones that started with an increased intracranial pressure. So they also believe that there is a reduction in CGRP expression as well. So they found that in the rats also. So again, this is a rat model of intracranial hypertension, but when they gave them the GLP-1 receptor antagonist, they saw a reduction in intracranial pressure, and they seem to see a reduction in CGRP expression as well. So back to that study that was published in Journal Headache. That study was 31 patients who had migraine, and it was high frequency migraine or chronic migraine. So quite frequent headaches. And they also had obesity, but they had no signs of increased intracranial pressure. So they didn't have pressure on their optic nerves. They didn't have a known opening pressure, a spinal fluid pressure that was elevated. They didn't have the features of intracranial hypertension. They had tried other treatments in the past for prevention of their headache that were unsuccessful. And they could be on preventive medications, the preventive medications that Dr. Crane and I often use. They just had to be stable. They couldn't change them at the same time they were starting the GLP-1. So then they were given a GLP-1 agonist for 12 weeks, and they monitored their frequency of headaches. They actually watched to see whether their weight changed, and then they looked at other quality of life scales associated with headache. The findings were I was really surprised when I read this, the amount that the headache frequency went down, reminding you that this is only for 31 patients, but still, I think this is quite significant. So the patients had, over that 3-month period on the medication, an average of 9.1 headache day reduction, and it's a headache days per month. Interestingly, though, also is the bullet point number 2. Their weight actually in that 3 months didn't change significantly as you average over the 31 people. The BMI went from 34 to 33.9. So in this study, at least half of the patients had at least a 50% reduction in their headache frequency. 23% of the patients had at least a 75% reduction in their headache frequency. And then there were 3 patients whose headaches went away. So pretty profound. Again, a very, very small group of patients and not a standardized, controlled trial that we would use like when we're testing our other headache treatments. And some of those are, hundreds, if not thousands of patients. So this is kind of a pilot study, but really, really interesting information that would suggest that we definitely need to study this more and study this drug more in treatment of migraine specifically, in addition to the work that's being done in elevated intracranial pressure. Um, I've kind of alluded to this, but just to kind of summarize this, I think it's good to summarize this, especially after presenting that study. So migraine, as I said in the beginning, is associated with, it's an activation of the trigeminovascular system. So that peripheral, that blue trigeminal nerve that innervates the dura and the scalp, and the sensory nerves of the trigeminovascular system are also highly innervating the meninges, the coverings over the brain that hold in the spinal fluid, and they're really concentrated near the veins in the dura. And those nerves release CGRP, the calcitonin gene-related peptide, that neuropeptide transmitter involved in migraine. So the thought is, and this is just a hypothesis, but the increased pressure, if people have increased pressure, whether it be because of intracranial hypertension or maybe just a slight increased pressure related to, maybe associated with migraine, that increases the pressure in the veins, and that activates the trigeminal nerve system and causes CGRP release and is involved in migraine. So the thought is, by lowering that pressure just a little bit with a medication like a GLP-1, can actually lower that trigeminal nerve excitation activation, lowering CGRP release and preventing migraine. Again, these are all hypotheses that if we could study this more, which I think that it will happen, we can find out more, maybe make some more sense of this, maybe prove or disprove these, maybe find more out about why there seems to be a strong association here. A couple of limitations of the studies. We don't know. What I presented on the last slide was hypotheses. But could there be something else? We call it a confounder. Could there be something else that we're actually treating and we're not actually treating? Maybe it doesn't have anything to do with pressure. Maybe it does. We know that pulling off spinal fluid in someone with migraine and lowering their pressure mechanically can help and often does help during a migraine attack. But could it be something else? Could it have a direct effect on reducing CGRP release, not through the pressure? Could lowering blood sugar somehow be involved in preventing migraine? Could it change some of the electrolyte levels, the electrolyte makeup in the spinal fluid or the blood? Perhaps. We don't know. There's a lot that's not known here. Other limitations, this wasn't a full placebo-controlled trial, and also to establish statistical significance, which means we can be confident enough that the treatment that we're providing is the data that we're getting is actually correct and not just by chance alone. They need a certain number of patients in the trial, so a statistician would determine the number of patients that we would need in a trial to do a full testing. The other thing is this was done in obese patients only, which leads to potentially some more questions of, does it have something to do, is there something specific in this patient population that's different that maybe led to skewing the results of the trial? So it would be interesting to do this test in patients who are not obese. And then the short study duration too, just over 3 months. They also didn't, one other thing is they didn't have a placebo arm in the trial. So patients who are not actually receiving the GLP-1, in fact, in this, they all got the drug. Back to
So
Dr. Crane.
Yeah. So how do these GLP-1 agonists work? So GLP-1, or glucagon-like peptide, is a natural hormone that our body produces on its own, and it's a key regulator of glucose metabolism and appetite. Agonist is a chemical that's created to act similarly to what we produce in our body. So as Dr. Knievel mentioned, it does work in the choroid plexus to decrease CSF production, but then the other ways that it works are to increase insulin secretion, which it does in a glucose-dependent manner. So it stimulates the pancreas to release insulin, but only when blood glucose levels are elevated, which helps reduce sugar spikes after eating. But because it only acts in response to high sugars, it doesn't cause hypoglycemia or low blood sugars. It also suppresses glucagon secretion from a different part of the pancreas. And glucagon is a chemical that decreases glucose produced by the liver, so also effectively preventing sugar levels from becoming elevated. They also slow gastric emptying, so they delay the rate at which the food is leaving the stomach, which also helps to blunt the rise of glucose or sugar after meals, and also gives that feeling of fullness earlier. And they reduce appetite and promote weight loss by working on receptors in the hypothalamus in the brain, which acts to decrease hunger and food intake. And this central effect is what significantly contributes to sustained weight reduction in many patients. And next slide. So what are the currently approved indications for GLP-1 agonists? Unfortunately, migraine and IH are not approved indications at this time, but I could definitely see that happening in the future with more robust studies. I included the medication name and the brand names here because this can be very confusing, as the same medication is branded differently for weight loss and for diabetes, for example. So one of the indications is chronic weight management. So BMI greater than 30 or BMI of 27 or higher with weight-related comorbidities like high blood pressure, high cholesterol, heart disease, etc. And those include liraglutide or Saxenda, which is actually approved for ages 12 and up, and semaglutide or Wegovy, and tirzepatide or Zepbound. And then, of course, these are used for diabetes as well. So just a different brand name of the same medications: Mounjaro, Victoza, Ozempic, and then also Trulicity, which is just approved for diabetes and not these other indications. Zepbound or tirzepatide has an approval for obstructive sleep apnea. Wegovy or semaglutide has a indication for fatty liver, as well as cardiovascular risk reduction and obesity. However, for that indication, you can't just have any heart problem or like a valve problem or a rhythm problem. You have to have specifically already had a heart attack, stroke, or diagnosis of peripheral arterial disease. So more indications are being studied and in the works for sure, but these are the main indications or FDA approvals at this time. And also it often depends on insurance coverage, as they're very expensive, and there's a wide range in differences between what plans will cover these medications. So that's a huge barrier and frustration with these medications, is having access to them. They're very expensive. Of course, if you have a prescription and you can afford it, you can definitely just pay for it out of pocket, but most people can't. And so insurance coverage is very specific about what they will cover and when. And there are some plans that will just cover them for weight loss, but most of them, the only way you can get them covered by insurance is by having one of these FDA approved indications and diagnoses outside of obesity. There are also compounded options, and those are getting a little harder to come by due to laws and regulations, but they are still available, and diagnosis doesn't matter as much necessarily, as you're not going through insurance to get these, and they are a bit cheaper, so that does help with access to them. But also keeping in mind, these aren't FDA approved versions of the drug. Compounding pharmacies are well regulated, and in my experience, these formulations do work well and have been helpful, but just noting that those aren't the FDA approved versions. And that's all I got.
Yeah, that's our last slide.
All right. Wow, what a fantastic talk. Thank you, Dr. Crane. Thank you, Dr. Knievel. What a fabulous discussion about GLP-1 agonists in migraine. I am looking over at the chat and I'm just going to let people think about their questions that they might have. And if you want to drop them into the chat, we would love to hear from you. This is exactly why we do these talks, so we can have discussions with the community. And if not, I have some amazing backup questions. So I might just start there and we'll see if anything trickles in. Okay, so we have, let's say I'm going to ask this to Dr. Knievel. I'm going to be starting a GLP-1 for weight management, or let's say I have sleep apnea. Do you think I can expect this treatment to also help my migraine?
I mean, I think so. I've been asked this question in my clinic before, and um, I hope so. I mean, we know that we've known for a long time that exercise is good for preventing migraine. Exercise leads to weight loss, but weight loss, even without exercise, just with healthy diet weight loss, helps to reduce the frequency of migraine. But then now I also think that there's a chance that just the GLP-1 medication can help with migraine too. So really, all things that kind of are associated with weight loss seem to help with migraine. So I would say yes, but for multiple reasons, not just because the GLP-1 necessarily would be a treatment for their migraine. Would this be a treatment that just based on this study I would start just for prevention of migraine? No, but if I have a patient with qualifying diagnosis that Dr. Crane reviewed, that could be helped by a GLP-1. Would I also know that weight loss would come from that and that would probably help their migraine? And would I also think that maybe they could get a direct benefit from the GLP-1 for migraine? Yeah, maybe. So yeah, yes, I would say yes, let's do it. And maybe it will help. Let's find out. And then let's wait for more information.
Okay, I like that answer. Dr. Crane, I'm going to ask you this question. How would I know if I'm a good candidate for a GLP-1 for migraine management?
Yeah, so I would say that you might be a good candidate if you have a diagnosis of obesity or are overweight and you do have some weight-related health issues, as well as very chronic or frequent migraines that haven't responded to other treatments and that could potentially be added on to help with the treatment. You should also not have any reasons that you can't take these medications. For example, you can't be pregnant, have a history of pancreatitis, certain types of thyroid cancers, or severe problems with the movement of your guts, like gastroparesis.
Okay, that's really interesting to know and helpful. I'm going to take a look in the chat real quick. Somebody was asking if someone's interested about learning about more current treatments, options, whether they with either how would they start with, like, that's actually a great question. Like, how would you approach your doctor about this? Like, I've been to this seminar or this talk, and how should they approach it?
Yeah, I would say don't be afraid to bring this up as an option with your primary care doctor as a potential treatment. You can mention that you've looked this up and read about it and are interested and have that discussion because you may have some factors that would be good or not so good. And then also considering being prepared and that you may or may not have access to the medication, but definitely don't be afraid to always be an advocate for yourself and bring it up. We're always happy to talk about these things and answer questions.
I love that. That's a great answer. And I love that you're bringing up advocacy and I think maybe going in that article and be like, listen, this is new
Yeah.
research that is potentially helpful. And I know that,
Yeah, you might know it and they might not.
true, also true. Okay. So, gosh, there's somebody asking about GLP-1 and effectiveness for fibro. And I'm going to say that for right now, we're trying to keep the questions specific to migraine. But maybe if offhand you guys know of any research for GLP-1s and fibro, do you guys know of anything there? No. Yeah. Well, okay. As someone with IH, Okay. Somebody asks, as someone with IIH and migraines, I have history of losing weight and regrettably no decrease of frequency of migraines. Since then, I have gained weight back close to my initial weight before my weight loss journey, and my migraines have increased. Would I be a potential good candidate?
Potentially, there's other things to think about. And anytime we see a patient, we're always thinking about, is there something else going on? And if someone has migraine and their headache frequency is not going down with our suspected treatment, then we start to think about other headaches, intracranial hypertension being one of those. And then we would consider working up for something like that. There's other things that we would want to keep an eye out for. But we also very often see that all of that workup is negative and it really is just refractory migraine. So we just continue trying other treatments. And if this treatment were appropriate, it would be something that would be absolutely something worth trying or at least considering.
Thank you for that answer. I think that that's a really good response. Somebody asked, will you be addressing help for migrants who aren't overweight? And I think you spoke to that some, but I don't know if you want to just kind of help this person out.
Yeah, that's just an even bigger, I don't know. I want to know the answer to that just as much as you do, actually. I don't know, but I want to think that based on this study that it could be, if weight had changed, then it suggests that there is a more of a component of weight contributing to this improvement, but weight did not change in this study, which is fascinating to me. And just a reminder in the study that it was all average. So some patients certainly did lose weight, some didn't, and perhaps some may have gained weight, but the overall average BMI over those 31 patients was the same. So I'd be interested to know that answer. And maybe there will be another indication for GLP-1s in the future, and it's migraine.
Yeah, it's fascinating. Okay, let's see. We've got some great questions coming in, you guys. Thank you for this. Could you see insurance approving GLP-1 if a patient has migraine, OSA, and fatty liver and obesity? And I mean, I'm not a doctor, but I'm going to say, like, I bet you that you're checking all the boxes, but maybe I'll give this one to Dr. Crane. What do you think?
Yeah, I mean, certainly with all of those, only one of those is really needed. Yeah, migraine itself, like I mentioned, unfortunately isn't currently an indication. I do think that's definitely a potential. But having those other indications, it's certainly possible that you would be able to get that medication and that it would be helpful for all of those things, including the migraine.
Yeah, as long as there are no contraindications, right? And what were those again?
The main contraindications are pregnancy, history of pancreatitis, medullary thyroid cancer in the family, and gastroparesis.
That was, yep. Thank you for that. Okay. Gosh, we got great. How many published studies look at this? Wait. What made you start your study? Was an anecdotal relationship noticed in GLP-1 related to? Okay. How many studies look at this? As far as I know, there's only one, right? There's this one from Italy.
Yeah, and so this wasn't our study. Yeah, it seems
Yeah,
like this was not our study. This was a study done in Italy that was published in Journal Headache. Yeah.
yeah.
I don't
Yeah.
know what led them to try this, but I mean I think it's really Alex Sinclair's work and other people doing the work in intracranial hypertension and then combining that with the fact that lowering spinal fluid pressure can improve migraine. So I think they kind of put that together and said, let's see if this works for migraine. The patients were being treated anyway for other indications, and they said, let's just as a side evaluate whether it helped their migraine attacks. And so I think that's how it came together as far as I could probably guess. But this is the kind of a pilot study, and so definitely more is needed in different patient populations, and then also probably doing a randomized controlled trial, which is where there's a placebo arm and people don't know whether they're getting the GLP-1 agonist or not.
Do you know if there's any such study being developed right now?
Not that I know of. We have a big headache meeting coming up, and I think this is probably going to be a topic there. So I think we might find out that other centers are doing it, but as far as I know, there isn't one yet. But I can see it coming.
Me too. Yeah, super exciting. Okay. As providers, how would you navigate the barriers to access and insurance? For instance, my insurance provider has an exclusion to weight-related treatment. Are there any other more readily available mechanisms that could help in a similar way? Maybe Dr. Crane can speak to that.
Yeah, so yes, most insurance plans, I would say, have that exclusion that you cannot use it just for weight related or just for weight loss, which I know is incredibly frustrating. And so we do then look to those other comorbidities. And if you have those, we try to get it approved in that way, which often takes a prior authorization and then an appeal. And then sometimes that way we can be successful. But even some insurance plans, they say, okay, well, now it's covered, but you still have a really high copay. And sometimes there's not really a whole lot we can do about that. I've had plenty of patients who I think would be excellent candidates for this medication. And there just are those barriers, and mainly financial. We can't get it covered by the insurance. And so I think it has been improving over time as we are getting more indications. So as more research comes out and more indications are added, and all of them are fighting to be the most competitive medication. So they're all working on all the different kinds of indications to be able to get them approved, which will be helpful. And as I mentioned before, sometimes we use compounding pharmacies to get these medications. So they're cheaper, and then we can also prescribe them. If maybe the insurance company won't cover it for whatever reason, then we can still get it to you that way.
Wonderful. Thank you for that. I think we have one last question here, and I'll see if I have any of my follow-up questions. If a parent had pancreatitis before passing, not pancreatic cancer, I guess a child wouldn't be eligible is their question. So do you think that would factor into if they'll be eligible for a GLP-1 if their parent had pancreatitis?
Oh, no. So it is either having a personal history of pancreatitis that would make this drug more risky. So if you yourself had pancreatitis, but certain types of thyroid cancer, and specifically medullary, which is pretty rare, is thought to be potentially exacerbated with this medication. And so we want to avoid that. And so a family history of that specific type would technically be a contraindication to it.
Okay, that was a good clarification. Okay, let me see if I had oh gosh, yeah. All right, we'll see who wants to take this one. The study follows a 12-week treatment program. Would these people potentially need to be on this medication long term, or is it something that would be shorter term?
Yeah, we don't know that. We have these patients, so if any of them went off of the treatment, we could see did their headaches worsen again. That would be another thing to kind of consider, but we really need a larger trial, more patients, maybe patients who aren't obese, maybe we just need other groups, but we need to study it more long term. For one, to see if they improve more after 3 months. Because in some of our other medications, we see that there is an improvement out to 3 months, but even out to a year, they even improve further. So could they even get more improvement is one of the unanswered questions. But then, yeah, at the end of the trial, when it stopped, do they worsen? And that's good to know too. Can this work as more of like a reset on their headaches versus is it something that they need to be on more long term? And we don't know the answer to that. All things that are going to come in the future, hopefully.
Yeah, it is very
Gosh.
likely that you would need medication for longer than 12 weeks for a few reasons. One of them is that the medications are often well tolerated, but to get them to be your body used to them and make sure that you're tolerating them, we don't start you on the highest dose. So we start on a low dose, and then we usually slowly increase that dose every month, and sometimes slower in some people. So some people only need low doses and get all of the benefits, and some people need higher doses before they see those benefits.
That's a great clarification. Thank you for that, Dr. Crane. Yeah, you must see a lot of that in clinic for sure. Well, gosh, is there anything else that people wanted to ask? I think we kind of covered like what do you think further research will be? And I think Dr. Knievel, you've spoken to that at length. And Dr. Crane, I mean, my last question was like, is there anything else about this topic that you think would be good? But you've like handed us information in spades. You've just been so wonderful of giving us all the pertinent information. So let me see if there's anything else in the chat.
While you're looking at that, I just had one other thing to bring up, and it's about sleep apnea and headache. People with obesity have higher risk for sleep apnea, and we know that sleep apnea can trigger headache and can also be associated with intracranial hypertension. So it can worsen migraine and intracranial hypertension, and often people don't know that they have sleep apnea. So for people with obesity especially, but also with headache, especially headache that's difficult to control, getting a sleep study for evaluation of sleep apnea is important because treating their sleep apnea with CPAP or however else that's treated is important for helping to treat headaches. But it can also then get you to help meet the criteria to qualify for one of the GLP-1 medications. So we do lots of sleep studies on patients in our clinic, especially refractory patients. And it doesn't always have to be a headache that wakes you up from sleep, or when you wake up in the morning, you have a headache. It could be an increase in the frequency of migraine, could be associated with obesity, but isn't always. So it's something that we don't always suspect, but sometimes I'm actually quite surprised that I find it in people. So it is something that I test in my refractory patients, and it can actually help with getting this medication approved.
That's really good that you shared that. Yeah. There was one last question, but I think we kind of spoke to it. But the question is there any study of what happens for migraine sufferers getting more migraines after stopping GLP-1? And maybe Dr. Crane, have you seen that? Anybody who stopped their GLP-1, did they start getting more migraines? Have you heard of that?
I haven't. I have read some cases of that happening, but I don't, from what I know, there's not really any studies about that. But I've also seen patients who get headaches from them, but that's usually when it's, they might be on too high of a dose and they're just not eating and not staying hydrated.
Got it. That's good to know about those side effects as well. We've got another question just came in. Because you mentioned gut balancing being one of the factors that helps migraine when the weight is lost in obese patients, what about people that are not obese? Are there any treatments you are using to help balance the gut in average or underweight people? Is that something you see in your non-obese headache patients?
Good question. So yeah, I mentioned rebalancing the gut neuropeptides, and that was in relation to or referencing what happens when you have like bariatric surgery. Because we think that, our stomach just doesn't hold as much, but also it changes the chemicals and the hormones, which is a huge factor in regulating obesity itself and what makes it harder to lose weight. There are many beneficial things. We know there's a huge connection between the brain and the gut, and that's super important. And there's many different thoughts and treatments. There's not one specific thing that I do specifically guided towards that.
Okay. I think it is really important to touch on that brain-gut connection. And I always love when they talk about that at the headache symposiums as well. Gosh, I think we've run out of questions, but we've answered some pretty amazing questions, all coming from our wonderful group online. So thank you guys for posing those questions. That's why we're here, for that engagement. And I want to thank Dr. Knievel and Dr. Crane. You've been both so fabulous in this whole talk. I can't wait to see how this sparks more conversation. I can't wait to see where this goes. So thank you for attending today's webinar. Our presentation is part of the larger program that we are offering here at Barrow called In the News, and there will be a new video each month to keep you up to date on all the news related to all the neurological conditions that we treat here. Thank you all for showing up, and a big round of applause to Dr. Crane and Dr. Knievel. Thank you so much.
Thank you. Thank you, Juliana. Thank you everyone for coming.